For the next chapter, we'll be talking about the hip today, and make for sure that you review all the anatomy and function that we discussed in PTA 150, including characteristics of the hip joint, ligaments associated, the movement of the pelvis with rotation as well. All the prime movers and secondary movers are also listed in your textbook. Please make sure you know Table 20.1, muscles of the hip. And then let's see here, the differences for anterior and posterior pelvic tilt, pelvic shifting, lateral pelvic tilt. A lot of that will be reviewed. So some things to really note before we get into nerve pain is really the muscle weakness and associated, especially with the hip. And there's a lot of connection between the hip, the knee, and the ankle and the functional relationship, especially with weight bearing. Then please review those mechanics as well. But for decreased flexibility, and a lot of times with weight-bearing forces or that are transmitted through the spine and through the pelvis, that there will be, for example, like tight hip flexors cause increased lumbar extension, which would be lordosis. And hip flexion contractures with incomplete hip extension during weight bearing also places some stresses on the knee because the knee cannot lock while the hip is in flexion unless the trunk is bent forward. So some other things too, muscle weakness, patellofemoral impairment. There's been links to, especially more so in women than in men, for patellofemoral impairments because of the higher valgus movements of the knee, and will result in weak hip abductors, as well as for ACL strains of valgus collapse and decreased hip extensor activation are more common in women, especially those that have sustained an ACL injury. Piriformis syndrome, hip extensor and hip abductor weaknesses are resulted in hip adduction and internal rotation, which would be a valgus collapse. And this is usually identified during functional activities and could possibly have compression on the sciatic nerve because of the piriformis muscle overuse. So all of these would be muscle imbalances and then their effects. Some other muscle imbalances could be the TFL, so a shortened TFL, tensor fasciae latae, or the glute max as well. So where the TFL and 1/3 of the glute max inserts into the IT band, so there's decreased flexibility to either of the muscles that are transmitted through the IT band. Some other things too could be because of a glute max with an anterior pelvic tilt posture, slouch posture, or flat back posture. Overuse syndromes associated with greater tension in the IT band include trochanteric bursitis in the hip region and IT band friction syndrome in the knee. So we'll look over some more of that IT band here soon too. The dominance of two joint hip flexor muscles over the iliopsoas. So the dominance of the TFL, rectus femoris, and or sartorius muscles can contribute to faulty hip mechanics or knee pain from overuse of the muscles that they cross at the knee. Another thing could be a muscle imbalance of the hamstrings over the glute maximus. So this would be resulting in a faulty posture, decreased functional activation of the glute max because of the utilizing the hamstrings over the glute max. And then therefore limited mobility of glute max also causes increased tension on the IT band as well. So looking over all these different imbalances is very important. Another imbalance would be lateral trunk muscles, such as your obliques, are being utilized instead of the hip abductor muscles. So if you're not seeing a pattern yet, with these imbalances, a lot of times it's because of patellofemoral impairment, the alignment, piriformis syndrome. If someone has had a previous ACL, then there's going to be issues onto the hip or muscle weakness. TFL, obviously with TFL tightness because it's making up for the glute medius or hip abductor muscles. Then also hip flexor muscles over the iliopsoas. And then the hamstrings could be tighter and utilized more so than the glute max. And then again, the obliques could be used for hip abductors. So obviously hip abductor weakness. Asymmetrical leg length, make sure you look at the differences of leg length. We've mentioned that before in PTA 150. But so Some other things just to point out: if there's a unilateral short leg, because it could be because of lower extremity faults such as flat foot, genu valgum, coxivera, tight hip muscles, anteriorly rotated non-bone bone, poor standing posture, or asymmetrical bone growth. Some other things too to keep note for unilateral, they could even have a a shorter or longer leg length on the operated hip from a total hip replacement as well. So if there is a leg length discrepancy and you you figure out it's because of the length of the bone post-surgical, then obviously whichever side is being affected, do not just put a heel lift. I've seen more benefits that they use either a custom-made shoe with a higher overall height and not just in the heel, because with a heel lift, they're going to end up with tight gastrocs as well, and possibly tight soleus. Also look at the review anteversion and retroversion. We've talked about that before. We've also talked about hip function and gait, especially the Trendelenburg gait pattern, so make sure you look over that. We've mentioned about sciatic nerve. Make sure you review observer nerve. The injury is rare. Femoral nerve can be resulted in from a fracture of the upper femur or pelvis, reduction and congenital dislocation of the hip, or possibly even from during labor and delivery with pressure on the forceps. So kind of just talked about that. So we're kind of look at a couple different things today. So hip OA, osteoarthritis, this is talking about non-operative management. Maybe you have an individual come in and for therapy because of hip pain. So maybe this is before they even have any kind of imaging, x-ray, MRI. So those are going to be like my first questions that I usually ask if it's not mentioned in the evaluation or by the PT. So some things to look for. So pain is usually experienced in the groin or referred along the anterior thigh and knee in the L3 dermatome. So as soon as they describe pain in the anterior groin, then I'm definitely going to be asking, did you have an x-ray? And then they're say, yes, it said osteoarthritis. Then I'm going to ask, do you know if it said mild, moderate, or severe? And they might not be able to tell you. Maybe they could bring in the report. Some other thing to figure out if it's OA, they're definitely going to have stiffness after rest because arthritis likes movement. So the more movement there is, and especially in the synovial joints, the more fluid is moving with that. Limited motion with a firm capsular infeel. So limitation is if it's only an internal rotation, but in advanced stages, the hip is fixed in adduction, has no internal rotation or extension past neutral, and is limited to 90 degrees of flexion. They could have asymmetry in lower extremity weight bearing on the antalgic gait, usually with compensated glute medius, have hip abductor limp and lower speed related to the shorter step length and stance duration. They could have limited hip extension leading to increased extension forces on the lumbar spine and possible back pain. Limited hip extension preventing full knee extension when standing or during gait, leading to altered knee stresses. And they could also have impaired balance and posture control. So obviously asking them about activity limitations, participation restrictions. I do have the Harris score. Look at it on Blackboard, and I definitely want you to look at that, please. For usually early stages of hip OA, there's usually progressive pain with continued weight bearing. So that's another key, asking if they have weight bearing more so, pain more so with weight bearing or walking, especially, the beginning stages might be just at the end of the day or repetitive lower extremity activities. Progressive degeneration, they'll actually have experiencing with difficulty rising from the chair or walking long distances or uneven surfaces, such as like walking in the grass or on carpet. They'll eventually have issues climbing stairs, squatting, other weight-bearing activities as well. They might have issues with ADL, such as bathing, toileting, and dressing, and putting on their clothes. So providing education, explaining how the stresses of weight-bearing other activities will impact their symptoms. So teaching safe ambulatory patterns and home exercise, program. You know, we're going to be talking about a couple exercises here, but, you know, some other things too, non-operative management that's described in your textbook. Let's see, where is it? On page 746, faulty hip mechanics may be caused by conditions such as obesity, leg length differences, muscle length, and strength imbalances, and SI joint dysfunction, poor posture, or injury to other joints linked to hip motion. So this is what we're going to be talking about for each one of these. So it's going to depend on the pathology. So you can perform grade 1 and 2 oscillation techniques to decrease pain. To decrease pain during weight-bearing activities, obviously having them utilize an assisted device depending on their age and their status and how much weight-bearing they can handle. So you might have to start off with a walker or to a cane, vice versa. If leg length asymmetry is causing hip joint stress, gradually elevate the short leg with lifts in the shoe. So we talked about that. No heel lifts, but there's actual like a lift throughout the bottom of the shoe. Modify chairs to prevent an elevated and firm surface and adapt commodes with an elevated seat to make sitting down and standing up much easier. So it's important to teach them to move the hips through the range of motion frequently throughout the day and have them perform active or active assisted range of motion as they're able to. Now, if a pool is available, then they would benefit from that because it'd be low impact, non-weight bearing, perform range of motion in the buoyant environment. So I shouldn't say non-weight bearing, but less weight bearing. Sorry, that was my dog. So doing some different stretching techniques and manual stretching techniques we're going to talk about here soon. There in your textbook they mention mobilization with movement techniques, so you can review that. Really not going to get into that too much because we already talked about joint lobes. So now talking about more so of surgery. So probably the biggest things too before we talk about surgery is the non-operative is, you know, just improving joint tracking, especially if it has to do with the knee, and improving with the muscle imbalance. Make sure you're improving with their balance as well, and aerobic capacity, providing patient education. So a lot of times, a lot of these exercises that you're going to include are probably going to trying to figure out what that muscle imbalance would be. So let's say if it's hip abductor weakness and IT band tightness, and you're going to stretch the IT band and strengthen the hip abductors. Maybe you have a patient do a straight leg raise and they're not able to. They're experiencing increased pain. So maybe you might start them off with supine marching, or even that way it's easier compared to standing marching. And then you can progress to standing marching, or maybe they can even do marching supine yet. Maybe just doing heel slides at the beginning. Then doing like sideline clams without resistance, and then progressing it with resistance. Maybe doing active assisted range of motion, hip abduction and sideline. You could have them do supine, heel slides into hip abduction, all these for hip abduction, you know, so progressing with that eventually. So if you want it to be non-weight bearing, you can have them standing in the parallel bars, and non-weight bearing, let's say it's your right lower extremity that's affected with osteoarthritis. You can have them do hip four-way without resistance and just to improve active range of motion. So some different stretching techniques you can do, see if it's more piriformis, hamstring, IT band, doing all those different stretches to see if you can improve the mobility. Probably a lot of quad stability you would probably have to utilize as well. So I think I talked about that enough. And it's really going to depend on the patient, and it's going to depend on the level of osteoarthritis or if they have a different impairment. So now I'll talk about arthroscopic procedures for the hip. So obviously we're going to be talking about total hip replacement and the different procedures. There's also a labral tear of the repair of that as well. So please look over labral tears. Probably won't get into much of that discussion for now, but make sure you look over that information. So for total hip arthroplasty, common indications for that is because of severe hip pain with motion and weight bearing and significant motion limitation and joint deterioration. Maybe they have because of OA, RA, or traumatic arthritis, ankylosing spondylitis, or osteonecrosis, or avascular necrosis. Maybe there's a fracture or non-union fracture, instability or deformity of the hip, maybe because of a bone tumor, or maybe because of a previous joint reconstruction procedure as well. Would be all indications of why they would have a total hip replacement. So there's some different approaches. There's some that are considered traditional or conventional or standard approaches that they still practice today, such as a posterior or posterolateral, lateral, anterolateral, anterior, and transtocanteric. So there's advantages and disadvantages to all of these. The posterior posterolateral approach is probably the most frequently used and still is approach for primary total hip arthroplasty. To access the joint through a posterior approach, the glute max is split in line with the muscle fibers. With a posterolateral approach, the interval between the glute max and medius is split. The piriformis and short external rotator tendons are transected near their insertion. The capsule is incised and the glute max tendon may be released from its insertion on the femur in preparation for posterior dislocation of the hip and insertion of the components. So even with the intact glute medius may result in early recovery of a normal gait pattern after surgery. Primary disadvantage of this approach is that it is associated with the highest incidence of postoperative joint instability and results of subluxation and dislocation of the hip. So to reduce the risk of postoperative dislocation, repair the posterior capsule and muscles advocated to improve soft tissue constraint to the posterior aspect of the joint. So for a direct lateral approach, there's a longitudinal division of the TFL, release up to 1/2 the proximal insertion of the glute medius, and longitudinal splitting of the vastus lateralis. The glute minimus also is partially detached from the trochanteric. The lateral approach may also involve a trochanteric osteotomy. So disruption of the abductor mechanism is associated with postoperative weakness of the muscle group, which leads to gait abnormalities in a positive Trendelenburg sign. The anterolateral approach, the incision is centered to the greater trochanter, lateral to the TFL. The IT band is split, and the anterior 1/3 of the glute medius and minimus are detached from their insertion of the greater trochanter, and then to be reattached at closure. Sometimes the anterior 1/3 of the vastus lateralis is detached as well. So unlike the posterior lateral approach, the external rotators usually remain intact in the anterolateral approach. The capsulotomy is performed and the hip dislocated anteriorly for adequate exposure of the joint. So although this approach allows for precise implant positioning, leg length correction, and excellent postoperative stability, it is associated with delayed recovery of the abductor muscles. So therefore, there'll be gait asymmetry, persists for a longer period of time with an anterior approach. Compared with the posterior approach, the incidence of postoperative dislocation is lower in the anterolateral approach. So it is indicated for patients with muscle imbalances associated with stroke or cerebral palsy, whose standing posture is characterized by hip flexion and internal rotation. Joint position places them at a higher risk of dislocation with a posterior approach. With an anterior approach, the incision is made on the lateral, distal, anterior, superior iliac spine, slightly anterior to the greater trochanter, and medial to the TFL. Although no muscles are detached with this approach, the rectus femoris and sartorius are retracted medially for exposure of the joint. The capsule is incised, the hip is dislocated anteriorly in preparation for insertion of the components. An advantage of the direct anterior approach is that weight bearing is tolerated and permitted immediately after surgery. However, this approach is used infrequently for primary total hip arthroplasty because the visualization of the surgical field is more challenging. For the trochanteric approach, this approach was first used with the very early primary total hip arthroplasty, but is now used primarily in complex revision arthroplasty. Involves an osteotomy of the greater trochanter at the insertion of the glute med and minimus and affords excellent exposure for insertion of the prosthetic components. The trochanter is reattached and wired in place to stabilize the osteotomy site. The trochanter is often attached or reattached in a position to improve the mechanical efficiency of the glute medius muscle. An extended period of non-weight bearing and adherence to abduction precautions are required until bony healing has occurred. Complications with trochanteric osteotomy include non-union and greater than usual soft tissue irritation and pain from considerable amounts of internal fixation. Traditionally, a total hip arthroplasty is minimally invasive in an open procedure. The joint is approached through one or two small incisions, usually less than or equal to 10 centimeters in length. The rationale for choosing minimally invasive THA over traditional THA is that of the smaller incisions and muscle-sparing techniques reduce soft tissue trauma during surgery, potentially improving and accelerating a patient's postoperative surgery or recovery. Okay, I'm going to move on down. So make sure you review all the different complications that are associated with a total hip arthroplasty, how that would look like, and it talks about dislocation and how frequently the first 2 to 3 months postoperatively is most frequently. Talk about leg length a little bit more in the positioning for that. For early mobilization, there's no need for immobilization of the operated hip. So early movement is encouraged, and although regularly move the hip through allowed or available range of motion, and the per restrictions as well. So immediately after surgery, they are allowed to permit weight bearing as tolerated. But, obviously having them utilize assistive devices until the muscles surrounding it and that the capsule is strong enough to adhere or have full weight bearing. Further strengthen the case for early weight bearing is already established that many patients have difficulty learning and integrating prescribed weight bearing limitations into functional activities. So therefore, it's really important to make for sure that you're educating your patients accurately and correctly. There's accelerated rehab that's been mentioned too, that, especially those under 60, 65 years of age, and they quickly want to resume active lifestyle. There's an accelerated rehab program, and to where they rapid progression to full weight bearing during ambulation, discontinuing crutch and cane use as soon as possible. But however, there are concerns of the postoperative strength and balance deficits and possible gait asymmetries and increased risk for injury. So, I kind of already talked about for a hemiarthroplasty, that would be like a partial hip arthroplasty, and indications for surgery. So make sure you look over for the indications of why they would decide to do a hemi. So there's different risk factors associated, so make for sure that you look for that as well. Now I'm talking about more so for fractures, but let me get to, make sure you look over this as well on Brigham and Women's, the hip arthroplasty and the different phases associated. We will go through each one of these. knowing for posterior precautions, anterior precautions, direct anterior precautions. So make for sure you memorize these different motions that you need to limit. Also with weight bearing restrictions and what the differences are between that. During lab, I'm going to have you go through the different phases, but go ahead and review all this information. That way you are prepared for lab. Make sure you're aware of all the different precautions. Be aware of the signs of hip dislocation, especially if there's uncontrolled pain or obvious leg length discrepancy. How to, for positioning and bed positioning, make sure you look over this as well. This is very important too, of all the different exercises associated that I want you to look over and what you would do during the first phases. Then getting into weeks 1 to 6. So make sure you're reading over all of this protocol here, and then we will talk about each of the exercises at a later time in lab. Okay, let me see here. Look. So for a ORIF, which is open reduction and internal fixation of the hip fracture, so there's different weight bearing considerations. So the amount is always determined by the surgeon, and it's on an individual basis depending on factors that influence the patient's age and bone quality and fracture location and pattern. Recommendations range from either non-weight bearing or toe touch weight bearing, partial weight bearing as well. There's many fixations procedures and to make early weight bearing possible. So make sure you look over each one of those and the goals to improve strength in upper and sound lower extremities, prevent postoperative reflex inhibition in hip knee musculature, restore mobility and control of the operated hip. So there's different exercises that are mentioned. Ankle pumping exercises performed regularly throughout the day to maintain circulation and reduce the risk of DVTs. Deep breathing exercises improve strength in upper, sound, and lower extremities. Targeting muscle groups that are used to lift body weight during bed mobility, transfers, and ambulation. Emphasize on closed chain training with most weight on the sound extremity, such as bridging exercises as well. Weight shifting activities and bilateral stance, heel and toe raises and bilateral stance. Isometrics, rhythm and stabilization, balance activities, bed mobility, so on. So make sure you look over all of that information. There's some other pathologies too, tendinopathies, muscle strains, repetitive trauma, bursitis, psoas bursitis. So we've kind of talked about bursitis before, so make sure you look over that. There's impingement, so a lot of times there's pain, gait deviations, muscle imbalances as well, decreased muscular endurance. Make sure you look over the different phases for management for kind of similar to like the healing phases, but this is more the protection, controlled motion, and return to function phases. And then I am going to pull up your textbook here. So just kind of as a review, hip OA, make sure you know common impairments in structural function. These are different predictions, like it's for diagnosing hip OA. So they say that 3 out of the 5 variables that were present, they had the likelihood of OA probability. So this is during the management phase, decreasing pain at rest, and we kind of already mentioned all these. So they talk about mobilization with movement, so I'm going to move on. Let me get to... so make sure that you look over each one of these because they talk about a labral tear and exercise guidelines, weight bearing restrictions for each of those. So all these about total hip arthroplasty, I kind of mentioned already, just briefly. They talk about the design and what kind of, so all these you need to know: direct lateral approach, anterolateral approach, all these as far as by definition, and which one to be minimally invasive. The other thing too that I didn't mention, like for an anterior approach, one of the main reasons why they don't like to usually do that too, because there's more blood loss associated. Let's see here. Okay, so like a lot of that information kind of just highlighted over, so make for sure that you're really looking at each one of these. You know, I mentioned it on the protocol, but for posterior lateral approaches, you need to know which motions that would need to be avoided, especially for each one of these, and precautions associated. Okay. Just making sure I got all of the information I wanted to. So here's the humeral arthroplasty of the hip indications for surgery. So these are the main indications. So if there's acute displaced intracapsular fracture, proximal femur, poor bone quality, failed internal fixation, severe degeneration of the head of the femur. So those would all be indications to just do like a partial replacement. Talking about, so here's all these awesome pictures too, as far as like what the reduction internal fixation would look like for the femoral head. Okay. So signs and symptoms of possible failure of an internal fracture fixation mechanism. Make sure you kind of look over that information. Any kind of precaution associated. So this was good too. They have several different studies that were mentioned for exercise programs following surgery for hip fractures. What they found features for exercise. Okay. Make sure you know the differences for tendinopathies and muscle strains, repetitive trauma, bursitis, the differences of these three different bursa and bursitis associated. Okay. So again, look over those. And then I did want to pull up. So yeah, make sure you review total hip arthroplasty protocol. There's also IT band syndrome, and make sure you read over all this information as well. Very helpful information and indications for therapy. And let me see here. So in all the different goals associated to improve IT band, and they talk about for each phase, they even mention different modalities such as ionto and ultrasound that help decrease pain. Also taping for patellofemoral symptoms. Also all the TheraX associated with stretching and strengthening. So make sure you look over all that information as well. There is another protocol on Brigham and Women's, which is for impingement. So make sure you look over the impingement as well. And we'll talk about some of these. There is a couple different resources on Blackboard. And so, but make sure you look over this impingement as well. And they have some awesome exercises in here for each phase that you can look over. All right, so a lot of reading. As far as replacements go, obviously a hip replacement, just in general, does not usually take nowhere near as long of recovery time when compared to like the hip or the shoulder. So relatively, it's a pretty quick recovery, and a lot of times they might not even come to outpatient very long or even be in inpatient very long either. So, well, thank you. You all have a great day. Thanks.